Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this upcoming video, which is part of a live demonstration of Webinar 10 in the ISSPS 2021, it gives me great pleasure to welcome Dr. Osman from Ipoh in Malaysia to demonstrate to us through various scenarios as to how we can use point-of-care ultrasound as part of a shock protocol in the emergency department. If you like any of our videos, do remember to like and share these videos with your friends and colleagues. If you're new to this channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
First and foremost, I would like to thank Professor Manoj Kamakar and his team for inviting me for this live webinar series, whereby I'm going to discuss about the point of care ultrasound shock protocol for anesthesiology. I will start this presentation by sharing this real case scenario of 45-year-old gentleman that presented to us in visual difficulty breathing, fever for 3 days. On arrival, he's tachypneic, he's drowsy, he's tachycardic, he's hypotensive, which sign of shock. Lung shows a crepitation mainly on both lower zone. RTK-PCR turned out to be positive. ABG shows some metabolic acidosis with partial compensation. I think by now we know the difficulty in doing ultrasound, especially with full PPE in COVID-19 patient. This picture exactly describes the thing that we have to face every time we want to do a focused cardiac ultrasound for the focused ultrasound in COVID-19 patient with full PPE. This is the lung ultrasound. We have a lecture on the lung ultrasound previously. On the patient left lower zone shows a hypertization. On the right middle zone shows what we call it the B line, and described by Giovanni Vercelli as a light beam phenomenon. This is the focused cardiac ultrasound. I will discuss in detail about this as we go along. Over the time, there's probably more than 20 protocols discussing how to use point of care ultrasound, especially in shock. Just to share few of these protocols, for example, access, the rush, the simple, the fit, etc. But almost all of these protocols, I give an example, this famous protocol called RUSH, a rush protocol, which stands for rapid ultrasound in shock protocol. They're discussing about three main fundamental parameters, which is the pump, assessment of the pump, assessment of the tank, and assessment of the pipe.
This protocol, you find that this three step, it further divide into 1, 2, 3, whereby, for example, in assessment of pump, we look at whether there is a pericardial effusion. We look at the left ventricle contractility, others hyperdynamic as normal or decrease. We look at the right ventricular strain, whether it's increase in size of right ventricular or whether there is a sign of septal displacement. For the tank, we're looking at SIVC, whether it's large or small. We look at the internal jugular vein, whether it's small or large. We look at the possibility of tank leakiness. For example, we do the EVAS, and we do the lung ultrasound, looking at possibility of B line and possibility of pulmonary edema, and we look at whether the tank is actually compromised, looking at the possibility of tension pneumothorax by determine whether absence of presence of lung sliding, and look at the covetals. When we assess the pipe, we look at the possibility of abdominal ultimate aneurysm. We look at the other part of thoracic aorta, whether there's possibility of aneurysm and dissection. We look at femoral vein, DVT, whether it's compressible. and also we look at the popliteal weight DVT.
We published this a few months back, whereby we discussed the potentially useful focus application in COVID patient. But true fact, this also a potentially useful focus application in any shock patient. And the most important thing when we discuss before we go further depth into how to use focus in shock patient, the most important initial thing that you need to do is to assess the cardiovascular, whereby you need to screen for pre-existing disease, the possibility of etiology, things like a myocardial dysfunction, looking at myocardial diagnosis, etc. And this is my 6-step approach in shock patient. I purposely divided into the first 5, which looking into the hemodynamic perspective, and the last usage of point of care ultrasound in guided invasive procedure. We know that hemodynamic failure in COVID-19 is real. The main reason why this happened is because of the same pathophysiology that occurs in any sepsis, which is the vasodilatation and microcirculation dysfunction, and cause all this LV and also RV failure. The question now is there any characteristic of COVID-19 patient which differ with patient non-COVID? And we know now, one of the complications that we see a lot in COVID patient is LV failure that caused by myocarditis to a point patient are presented with heart failure and even arrhythmia. And a lot of evidence have shown those with cardiac injury, those COVID patients with cardiac injury, the prognosis is poor compared to those without cardiac injury. And when we look into the echocardiographic patterns of this cardiovascular dysfunction in COVID-19 patients, what we found that almost 50% of patients that have normal echocardiographic findings. And those with RV dysfunction seems more likely associated with increase in terms of mortality. So that's the reason why before we decide on any management based on our plan of care ultrasound, we need to go back into the basic, looking at hemodynamic consideration, especially in hypotensive shock patient. We know that there's a 2-type volume, what we call a stress volume and non-stress volume. Stress volume is the one that generates pressure, whereby when we go back into the physiology, the stress volume, they're the one that determine the mean systemic filling pressure. And this systemic filling pressure is the one pressure that push the blood from point A, which is after the LV, into the arterial circulation, back into the right side of the heart. And the other basic fundamental hemodynamic, that we need to understand is what we call a venous return gradient. So looking back into this Frank-Starling curve, we know this is a normal cardiac function curve. But the true fact is, when we give fluid resuscitation of fluid bolus, our aim is to increase the venous return, so that by this, we might increase the mean systemic filling pressure. And if you look back into right atrial pressure, your CVP, get not much different. But in most ill patients that we saw, those patients that have a pre-existing cardiac problem, they have cardiomyopathy, there's heart failure, they have other comorbid that increase the risk of having a limited in terms of physiological, cardiac, and respiratory reserve. And this is just example in those with impaired cardiac function. So you can see here, by increasing fluid, we not even that will increase in CVP, that's not much different in terms of cardiac increasing in cardiac output and venous return. This is very important. That's the main reason why CVP is no more popular now as a part of the monitoring in patient in shock. So going back into this 6-step approach, if you look back into the step 1, whereby we need to look into the overall cardiac morphology, looking for pre-existing cardiac chronicity. Okay, I just give her two examples. This is a two different patient, patient A, patient B, with the same cardiac output. And you can see in patient A, if you give fluid, there's nothing much going to happen. But if you give fluid in this excess fluid in this patient B, this patient will go into acute cardiogenic pulmonary edema. Then you can see there is limitation in terms of cardiac reserve. This patient won't be able to tolerate excess fluid. Just to illustrate the example, emphasize the example. This is a patient with a dilated cardiomyopathy, those with a chronic pulmonary hypertension with dilated RA and RV, and patient with hypertrophic cardiomyopathy. The other possibility, the usage of this point of care ultrasound is to look at the possible etiology. I give good example. This is a patient that presented to us with septic shock. And based on our focused cardiac ultrasound, shows this patient is having a mitral valve acute endocarditis involving the posterior mitral reflex. You can see a vegetation there. And this patient, similar, okay, presented to us with a septic shock, but this patient is having anterior mitral reflex vegetation there, you can see, and a possible perforation. Right, this is a real case that we saw a few weeks ago. This is two young patients that presented to us both with COVID-19 related myocarditis, and you can see there's a reduce in systolic and diastolic function. Similarly, you can see there is in terms of echogenicity, is hyperechogenicity, and because of the ECG changes and elevated in cardiac enzyme and in fact cardiac function, we come up with diagnosis of COVID-19 related myocarditis. This is another patient that presented to us in septic shock with a pericardial effusion. In this patient, there is a cardiac tamponade. Right. The second thing that we can use point of care ultrasound is looking at the preload assessment and fluid responsiveness. This is a simplest way to do it. Based on this Frank-Starling curve, you can look at left ventricle and diastolic area, right? But the thing is, the limitation of this technique, the LV compliant, meaning simple English, there must be no history of abnormality or pre-existing cardiac abnormality. So to start with, the LV must be normal. There's no dilatation in the left ventricle, etc. Right? So you can use this. Yeah, looking at similar. Okay, looking at the left ventricular and diastolic area, you can determine whether which part of the Frank-Starling curve patient is actually in. Right. The one that we use a lot now is this IVC, in which based on physiology, which kind of explain why it's been used to look at the fluid responsiveness and fluid part of the preload assessment, right? And because of the change in the intrathoracic pressure, yeah, there will be change in the diameter of IVC. It's just a bit of example, okay? But the most important thing, you need to do a dynamic IVC measurement, right? A dynamic IVC measurement. And you can see there is a variation in IVC, okay? And you can determine whether the patient is fluid responsive or not fluid responsive.
One of the best way to assess the preload and to determine the fluid responsiveness is by looking at the SV variation. And if we look back into this video, this is LVOT, this is LA, and this is LV. So stroke volume of VTI, this is the VTI envelope. This VTI represent the amount of blood that goes into the LVOT every time the LV contract. And this is the best representative or surrogate for stroke volume. And of course, we know that LV root is constant, So this is the best way to represent the cardiac output. And how to do it is just by putting the PW sampling at the tip of aortic leaflet, and what you get is this envelope. And from this envelope, you can determine whether there is a variation during inspiration and expiration.
To give an example, this is a patient with a fluid responsive. Okay? You can see the variation during inspiration and expiration. This is the superior vena cava. Of course, this is TEE, transesophageal echocardiography, right? And this is the IVC, right? And you can see there's a variation during inspiration, expiration, and meaning there is a IVC variation and also the VTI variation, right? And this is patient that are non-fluid responsive, whereby you can't see much difference in terms of during inspiration, expiration, similar kind of static dilated IVC without any change during inspiration and expiration. So it's non-fluid responsive. But I would like to bring you to this quite interesting test called passive leg rising test. In fact, not many tests in medicine that achieve the sensitivity and specificity is almost perfect. It's almost 100%, which is PLR, basic leg rising test.
The basic fundamental based on physiology for basic leg rising test is quite simple. By elevate the upper torso, we actually push the fluid, the blood, into lower limb, and by elevate the lower limb, we're actually pushing back the this almost 300 to 450 ml of blood back into circulation. So those patients with a fluid which is formed under category of fluid responsive, we show some changes in terms of VTI and in terms of stroke volume. This is just to give an example. These cases that we saw that presented to us with a septic shock. Of course, in this case, we use a transesophageal echocardiography. Reason why, because we're having problem to use the transthoracic echocardiography. But you can see here, there's not much changes in terms of VTI. So this patient is not in the fluid responsive category. You can see in some patient, this is another patient that presented to us. This is before we elevate the lower limb, and this is after we elevate the lower limb. I can see there is a SP stroke volume variation after and before PLR, which is more than 12%.
This is not the usage of this point of care ultrasound, whereby you can use it in determine the effectiveness of vasopressor and also anotropes. This is patient that presented to us in septic shock, septic cardiomyopathy to be exact. This is before we start patient on any vasopressor. This is when we start patient on NORAD and dobutamine. This is when we increase the NORAD and the dobutamine. You can see number one, okay, there's increase in terms of myocardial contractility, okay, in terms of systolic function. Because when we give inotrope, when we start patient a vasopressor inotrope, for example, what we want is actually to stimulate the beta adrenergic. And you can see from here, you're able to actually increase the systolic function of this heart. And of course, similar, you can do a VTI, and you can see there's such difference in VTI, increase in VTI, and you can see the variation before and after you start on a fluid, or after you start patient on inotropes. The other thing that you can use point of care ultrasound is subjectively, you can look at the preload assessment. This is just an example. This patient is hypovolemic, first patient. The second patient is patient presented with septic shock with a severe vasoplegia. Okay. Simple way to do it is looking at the end-systolic area and end-diastolic area. Okay. In both conditions, in hypovolemia and vasoplegia, there's not much changes. Okay, there is a reduce in low in end-systolic area, whereby in hypovolemic, because of the intravascular volume depletion, they also will be low in end-diastolic area. And because in vasoplegia, the main pathophysiology is a generalized vasodilatation. And most of the time, not much different in terms of intravascular volume. So there will be normal during end diastolic area. Okay, so this is we call it just a subjective way to determine, to differentiate and looking at the afterload, okay, to assess the afterload. So in summary, this is the 6-step approach that I suggest that we probably can use in patient in shock. Number one, we look at the overall cardiac morphology, chronicity, and possible etiology. Number two, we'll look the overall cardiac functionality. Basically, the most important, the LV systolic and diastolic function. The RV global systolic function. You can estimate the cardiac output, even though it's normal basic focused cardiac ultrasound. But honestly, I think if we're able to do the VTI, this is one of the surrogate of stroke volume and also the cardiac output. And the most important thing, we can use it in the preload assessment and looking at the preload responsiveness. In some patients, even this is just subjective way to assess the afterload. You can estimate roughly the patient afterload. Okay, and last, we can use in ultrasound guided invasive procedure. With that, thank you very much. Thank you for your attention.